Therapeutics options for pediatric neuromuscular disorders. An update. Neuromuscular disorders, NMDs, include conditions affecting the anterior horn cell for example, spinal muscular atrophy, =SMA, the peripheral nerve, for example, Charcot-Marie tooth disease, =CMT, the neuromuscular junction, for example, congenital myasthenia, or the muscle itself, for example, Duchenne muscular dystrophy, =DMD. In general, NMDs are progressive, impair motor function, and often reduce life expectancy as well as quality of life. Most of the more prevalent NMDs have been first described at the end of the 19th century. Although the genetic basis of these disorders has been unraveled during the last century, treatment remains symptomatic or even palliative for many decades. The vast majority of NMDs manifesting in childhood have a genetic basis. Therapeutic agents targeting to treat these conditions can either attempt correcting the genetic defect or try mitigating the pathophysiological consequences that originate from the genetic error. NMDs as a whole are not infrequent, but every single one is a rare or orphan disease. Prevalence, 1 per 1,500 persons in the U.S. and 1 per 2,000 persons in Europe. An orphan drug is a pharmaceutical agent developed to treat medical conditions which, because they are so rare, would not be profitable to produce without government assistance. Acknowledging the need for better care of patients with rare diseases has led to legislations in the U.S. and in Europe that resulted in tax incentives, enhanced patent protection and marketing rights, and research subsidies encouraging pharmaceutical companies to develop orphan drugs. These measures, together with recent progress in the understanding of pathophysiological mechanisms underlying specific NMDs and in genetic engineering, has resulted in the development of several highly innovative pharmaceutical agents for children with NMDs. Diseases of the anterior horn cell, spinal muscular atrophies, SMAs. Spinal muscular atrophies are characterized by premature degeneration of the second motor neuron. 5Q-associated SMA is by far the most common form, with an incidence of about 1 in 6,000 to 10,000 live births. The phenotype is broad and ranges from infants dying within the first year of life due to respiratory insufficiency to patients showing first symptoms of mild proximal muscle weakness beyond the age of 18 years. The disease is caused by biallelic mutations in the survival motor neuron, SMN1, gene. SMN1 encodes the SMN protein that is ubiquitously expressed and essential for proper function of the anterior horn cells in spinal cord and brainstem. About 95% of patients carry homozygous SMN1 deletions of exon 7 or exons 7 and 8, resulting in a truncated and unstable SMN protein. Humans have 8 copies of a paralogous gene, SMN2, located next to SMN, one that differs by 5 nucleotides. This results in a splicing defect, diminishing the SMN protein produced by 1 copy of SMN to tell 10% of the normal value. Based on age at onset of clinical symptoms and best motor function, 3, 5 SMA subtypes, SMA 0, 1, 2, 3 plus 4, are distinguished. While biallelic mutations in SMN1 cause SMA, disease severity is related to the number of SMN2 copies. The Food and Drug Administration, FDA, in 2017, and the European Medical Agency, EMA, in 2018, approved nusinersen, Spinraza registered trademark, an antisense oligonucleotide that modifies the splicing process of SMN2, thereby enhancing the production of stable and functional SMN protein for all patients with 5Q-associated SMA. Since nusinersen does not pass the blood-brain barrier, it has to be administered intrathecally every 4 months following 4 loading doses within the first 2 months. A multi-center placebo-controlled phase 3 study, including 121 SMA-1 patients, demonstrated that significantly more nusinersen-treated subjects were alive and that they had better motor functions at the end of the trial than untreated individuals. Similarly, a study with 126 SMA-2 patients aging 2 to 9 years displayed that subjects receiving nusinersen had significant and clinically meaningful improvement in motor function compared to untreated patients. Finally, an observational study with 19 adult SMA-3 patients receiving nusinersen for 10 months showed motor and respiratory improvement. Onasemnogene abiparvovec, Zolgensma registered trademark, is a AAV9 vector-based gene therapy approved in 2019 by the FDA for children with SMA under the age of 2 years, and by the EMA in 2020 for SMA1 patients, and for all SMA subjects with up to 3 SMN2 copies, regardless of their age and weight. The adeno-associated virus subtype 9, AAV9, is able to cross the blood-brain and to transfect motor neurons. The vector contains a single-strain copy of the SMN1 gene that persists in the cell nucleus as an extrachromosomal episome. The drug is given as a one-time intravenous infusion over 60 minutes. An open-label study including 15 SMA1 patients showed that all patients were alive and without permanent ventilation by the age of 20 months, compared to only 8% of patients from a natural history cohort. Moreover, some patients gained motor milestones such as sitting and standing not attained by any patient in the untreated cohort. A clinical trial evaluating the safety of intrathecal administration in patients with 3 SMN2 copies, NCT 03381729, is on hold at the time of writing, July 2020, because of dorsal root ganglia damage observed in non-human primates. Risdiplam, Everesti registered trademark, is a small molecule also modifying pre-mRNA splicing of SMN2. The drug is studied in patients with SMA1-3 and in pre-symptomatic SMA1 patients. Risdiplam can be given orally since it penetrates the blood-brain barrier. Preliminary data from clinical trials in SMA1 patients and from studies with children and young adults with SMA2 indicate improved survival and motor function compared to untreated patients. Based on these data, Risdiplam has been recently approved by the FDA and is available in Europe in the scope of a compassionate use program for SMA1 and 2 patients deemed as not suitable for treatment with nusinersen or onasemnogene abeparvovec. Currently, many SMA1 patients start treatment with one of the above-mentioned therapeutic agents after they have been diagnosed on clinical grounds. Although the efficacy of these new drugs has been well documented in clinical trials, improvement of motor function is often modest, and swallowing and respiration remain substantially compromised. This stands in sharp contrast to the results of studies with nusinersen and onasemnogene abeparvovec in pre-symptomatic SMO1 patients, showing that many of them achieve walking, learn to speak, and remain ventilator-free at least within the first years of life. These data strongly support inclusion of SMA into newborn screening programs. No head-to-head studies comparing the efficacy of nusinersen and onasemnogene abeparvovec are available. An indirect, unanchored comparison of the 2 pivotal trials among symptomatic SMSO type 1 infants suggested that onasemnogene abeparvovec may have an efficacy advantage relative to nusinersen, but this study has been criticized because of substantial methodological shortcomings. The availability of these very expensive new drugs raises many ethical questions, such as access to treatment and start or termination of therapy in patients with advanced disease. Unfortunately, guidelines defining standards of care have been updated for the last time shortly before these new therapies have been approved. Peripheral nerve diseases / Charcot-Marie tooth disorders, CMTs. CMTs are a heterogeneous group of hereditary motor and sensory neuropathies with a prevalence of 1/2,500. Age at onset varies from the neonatal period to adulthood. Clinically, patients have sensory deficits and usually show a slowly progressive distal muscle weakness and foot and hand deformities. Axonal and demyelinating forms are distinguished, and currently mutations in more than 90 genes are known to be involved. CMT1A is the most frequent form, accounting for about 60% of cases. The disease is caused by a duplication of the PMP22 gene. Peripheral myelin protein 22-KDA, PMP22, is produced by Schwann cells and has an important role in proliferation and differentiation of myelin. Overexpression of PMP22 protein leads to demyelination and abnormal remyelination with slowing of nerve conduction velocity, and over time causes secondary axonal degeneration. Different therapeutic approaches are currently under investigation, attempting to regulate PMP22 expression or enhancing myelination. PXT 3003 is a combination preparation of three medicaments: 3 milligrams baclofen, 0.35 milligrams naltrexone, and 105 milligrams sorbitol, with the aim to reduce the expression of PMP22. A phase 2 placebo-controlled study over 1 year was conducted in 80 patients with CMT1A. Patients in the high-dose arm demonstrated improvement in motor conduction velocities and in the overall neuropathy limitation scale, ONLS. Similarly, a phase 3 study with 323 patients ranging in age from 16 to 65 years taking PXT 3003 for 15 months showed an improvement in the 10-millage walking test as well as in ONLS in patients receiving the higher dose. Antisense oligonucleotides, ASOs, have been found to effectively suppress PMP22 mRNA in affected nerves in two murine CMT1A models. Initiation of ASO treatment restored impressively myelination, motor nerve conduction velocity, and compound muscle action potentials almost to levels seen in wild-type animals. These data demonstrate that strategies to reduce PMP22 have potential as effective therapeutic approaches for CMT1A. Neurotrophin 3, NT3, is implicated in the support, survival, and growth of Schwann cells and regeneration of peripheral nerves. Preclinical studies with human recombinant NT3 showed improved axonal regeneration and myelination, which resulted in a subsequent placebo-controlled phase 1-2 study, including 8 adult patients for 6 months. Patients who received NT3 subcutaneously experienced a clinical improvement as measured with the Mayo Clinic neuropathy score and showed improved regeneration of myelinated fibers in nerve biopsies. Because of the limited half-life of subcutaneously administered NT3, a preclinical AAV-mediated NT3 gene study was conducted in animals, showing improvements in motor function, compound muscle action potentials, and nerve biopsy findings, 40. Moreover, a phase 1-2 trial is ongoing with 9 patients aging 15 to 35 years treated with intramuscular injections in both legs of AAV1. TMCK, NTF3, NCT 03520751. Results are expected in 2023. While treatment of CMT1A is still symptomatic and classic pharmacological options have been disappointing, a recent randomized trial with L-serine in 18 adults with hereditary sensory autonomic neuropathy, HSON, showed that the CMT neuropathy score improved significantly in the treated group. Disorders of the neuromuscular junction, congenital myasthenic syndromes, CMS. CMS include a group of currently 30 genetically distinct entities, all sharing the symptoms of fatigable muscle weakness and impaired neurotransmission. Application of next-generation sequencing techniques has resulted not only in identification of new genes and proteins, but also in a better understanding of the pathophysiology of the neuromuscular junction. This has enabled a more tailored therapeutic approach. While drugs like pyridostigmine, an acetylcholine ACH esterase inhibitor, often used in tandem with 3,4-diaminopyridine, a potassium channel blocker increasing ACH release, are more or less effective in some of these conditions, they may worsen symptoms in slow-channel forms, in which prolonged ACH receptor-gated channel opening causes deleterious entry of K2+ into the postsynaptic region and consecutive degeneration of postsynaptic structures. In addition, treatment with sympathomimetics like salbutamol has been shown to be beneficial in subjects refractory to cholinesterase inhibitors. Moreover, HEH receptor open channel blockers, for example, fluoxetine and quinidine, have been shown to be effective in some of the slow-channel syndromes. Primary diseases of the skeletal muscle. Myotonic dystrophies. Myotonic dystrophy type 1 and 2 are dominantly inherited. Progressive diseases affecting multiple tissues due to unstable repeats in untranslated DNA. Myotonic dystrophy type 1, DM1, is the most prevalent neuromuscular disorder in adults and has a broad phenotype ranging from onset of myotonia and mild muscle weakness in adulthood to congenital forms characterized by severe muscular hypotonia, generalized muscle weakness, and respiratory failure in neonates due to aggravation of disease severity through successive generations. Anticipation. DM1 is caused by an expansion of a CTG repeat sequence in the 3-UTR of the myotonic dystrophy kinase protein, DMPK gene. This results in DMPK transcripts with expanded CUG repeats that are retained in the nucleus and form multiple discrete RNA foci, triggering a cascade of toxic effects. Tideglusib is an inhibitor of glycogen synthase kinase 3-beta that has been shown to reduce the amount of toxic CUG-containing RNA in DM1 mice. A phase 1/2 study including 16 adolescents and younger adults with DM1 has already been completed, but results are not yet available. NCT 02858908, and a double-blind placebo-controlled study assessing safety and efficacy in a smaller group of children with a congenital form is planned, NCT 03692312. Metformin is an anti-diabetic drug modifying RNA splicing, autophagy, insulin sensitivity, and glycogen synthesis that has been found to have positive effects on mobility and motor function in a small-scale monocentric phase 2 study. The pathophysiology of DM1 is extremely complex, and a bundle of small molecule compounds such as upregulators of the muscle-blind-like MBNL splicing factor family, HRAS pathway inhibitors, transcription inhibitors, and protein kinase modulators has been shown to mitigate DM1 pathogenesis in different experimental systems, giving hope that more clinical trials will start in the near future. Limb-girdle muscle dystrophies, LGMDs. LGMDs are a heterogeneous group of diseases characterized by progressive proximal weakness of the pelvic and/or shoulder muscles. Disease onset is usually after the age of 2 years, and the estimated prevalence is 100,000. CK concentrations vary from slightly to highly elevated, while muscle biopsy findings range from mildly abnormal to severely dystrophic. Autosomal dominant LGMD and recessive LGMDR forms are distinguished. Currently, more than 30 genetically different types are known. Sarcoglycans are proteins that form a tetrameric complex at the muscle cell plasma membrane. This complex stabilizes the association of dystrophin with the dystroglycans and contributes to the stability of the plasma membrane cytoskeleton. Dysferlin, or dystrophy-associated FUR1-like protein, is encoded by DYSF. Several lines of evidence indicate that dysferlin is linked with muscle cell membrane repair. DYSF defects can result in different forms of neuromuscular disorders, such as Miyoshi myopathy, MMM, limb-girdle muscular dystrophy, type R2, and distal myopathy, DM, LGMD-R4 beta-sarcoglycanopathy. Preclinical studies in SSS sarcoglycan-deficient mice treated with AAVR7 containing a B-sarcoglycan transgene targeting to treat skeletal, diaphragm, and cardiac muscles demonstrated functional and biochemical improvements. Currently, there is an ongoing phase 1/2 clinical trial with 6 patients ranging in age from 4 to 15 years. Results from an interim analysis in 3 patients after 9 months displayed improvement in motor function, reduction of CK, and increase of beta-sarcoglycan expression in the muscle. Final results are expected in 2021. LGMDR3, alpha-sarcoglycanopathy. Preclinical studies in AA-sarcoglycan-deficient mice treated with systemic AAV containing A-sarcoglycan using a muscle-specific promoter showed histological improvement, correction of pseudohypertrophy, as well as increase of global activity. This prompted a phase 1/2 study that included 3 non-ambulatory patients aging 12 to 14 years who received an intramuscular injection of AAVR74 containing an alpha-sarcoglycan transgene. All patients showed a positive gene expression in muscle biopsies performed on week 6 in 3 and 6 months. Similar results were obtained in 2 of 3 patients aging 23 to 43 years old, in whom muscle biopsies were taken 6 months after gene delivery. It was supposed that the negative results in the 3rd patient were caused by pre-existing immunity against the used vector. LGMD-R5, gamma-sarcoglycanopathy. Preclinical trials in G-sarcoglycan-deficient mice treated with intramuscular AAV containing G-sarcoglycan with a muscle-specific promoter showed histological improvement mainly in those muscles that did not show significant fibrosis. In a consecutive phase One study, 8 out of 9 non-ambulatory patients ranging in age from 12-14 years who received an intramuscular AAV1 injection with a gamma-sarcoglycan transgene showed a positive gene expression in muscle biopsies performed 1 month after application. LGMD-R2 dysferlinopathy. Studies in dysferlin-deficient mice treated with systemic dual adeno-associated virus vectors, AAVR74, showed histological and radiological improvement. Since DYSF is a large gene, 55 exons, it has been splintered into 2 fragments that are packaged into separate AAVR74 vectors. Both fragments have a 1 kb overlap region that allows the recombination of the 2 cDNA segments after systemic co-injection. Currently, there is an ongoing phase 1 clinical study that includes non-ambulatory adults with LGMDR2 who received intramuscular delivery of AAVR74 with the aim to explore gene expression after 3 and 6 months, NCT 0271050. Congenital myopathies. Myotubular myopathy. X-linked myotubular myopathy, XSTM, is a rare congenital myopathy characterized by severe muscle weakness, respiratory failure, and early death. Mortality rate is estimated to be 50% in the first 18 months of life. The disease is caused by mutations in the MTM1 gene that lead to absence or dysfunction of myotubularin, a protein that is necessary for normal development, maturation, and function of skeletal muscle cells. The disease affects approximately 1 in 50,000 newborn males. In a study with XLMTM dogs, intravenous administration of a recombinant AAV8 vector expressing canine myotubularin at 10 weeks of age demonstrated impressively that this treatment was well tolerated, prolonged lifespan, and corrected the skeletal muscle phenotype in a dose-dependent manner. This prompted a phase 1/2 study in children with XLMTM ranging in age from 0-5 years. While the first 6 patients dosed at 1x 1014 genome copies kg also showed very encouraging results, all 3 patients administered a 3-fold higher dose, 3x 1014, experienced severe hepatotoxicity, and 2 of them died. Further development of this product is currently on hold, pending further evaluation of these serious adverse events. Dynamin-2, related centronuclear myopathy. Mutations in DNM2 encoding dynamin-2 cause autosomal dominant centronuclear myopathy, which is associated with variable muscle weakness and wasting. In DNM2 mutated mice, weekly intrapleural injections of ASOs targeting DNM2 for 5 weeks corrected muscle mass, histopathology, and muscle ultrastructure. These findings prompted an ongoing phase 1/2 study with DYN-101, a synthetically manufactured constrained ethyl gapmer ASO directed against DNM2 pre-mRNA in 18 adolescents and young adults. Lamin AC-related muscle disease. LMNA-related disorders are caused by mutations in the LMNA gene, encoding the nuclear envelope proteins lamin A and C by alternative splicing. LMNA mutations are linked with a wide range of disease phenotypes such as neuromuscular, cardiac, and metabolic disorders to premature aging syndromes. Neuromuscular phenotypes include LMNA-related muscular dystrophy, autosomal dominant Emery-Dreifuss muscular dystrophy, and congenital muscular dystrophy. Apart from symptomatic treatment, including the use of steroids, amelioration of pathogenesis by exon skipping has been proposed as a potential treatment strategy. Pompe disease. Pompe disease, glycogen storage disease type 2, is caused by biallelic mutations of the acid alpha-glucosidase, GAA gene. This results in deficiency of the lysosomal enzyme GAA and impaired autophagy. Severity of disease depends on the amount of residual enzyme activity. 2 types are distinguished: infantile and late-onset Pompe disease, IOPD, LOPD. The incidence of IOPD is about 140,000, and that of all types amounts to approximately 140,000 in Europe. In classic IOPD, GAA activity is 1%. Contrary to milder forms with later onset that are characterized mainly by a progressive proximal myopathy with early respiratory involvement. This causes marked accumulation of glycogen not only in skeletal muscle, but also in heart and other tissues. Affected patients present with CK elevation, hypertrophic cardiomyopathy, failure to thrive, muscular hypotonia, and axial muscle weakness during the first 6 months of life. IOPD is rapidly progressive, and the majority of untreated subjects die within the first year of life due to a combination of ventilatory and cardiac failure, without achieving any motor milestones such as turning, sitting, or standing. Survival beyond the age of 18 months is exceptional. Although GIA activity is 1% in all IOPD patients, two groups have to be differentiated. Patients may synthesize a non-functional form of GIA or are completely unable to form any kind of native enzyme. The former patients are designated as cross-reactive immunological material, CRIM positive, whereas the latter are classified as CRIM negative. An enzyme replacement therapy, ERT, with recombinant human alpha-glucosidase, Lumazyme registered trademark / Myozyme registered trademark, was approved in 2006 by the FDA and the EMA. The recombinant enzyme has to be administered intravenously every 2 weeks over about 4H. In the pivotal phase 3 study, including 18 infants diagnosed before 6 months of age, all patients were alive and 7 walked independently after 12 months of ERT. In a follow-up extension study over 3 years, 13 patients were still alive and 6 remained able to walk. In addition, a placebo-controlled phase 3 study was performed in 90 ambulant LOPD patients about 18 months. This showed that treated patients had significantly better motor function, measured by the 6-MWT, as well as stabilized pulmonary function. The positive results of the pivotal IOPD trials have been confirmed by several real-world studies, but it has been recognized over the years that the response to ERT is imperfect, and that patients respond differently. A beginning of ERT as early as possible and immunomodulation in CRIM-negative subjects to avoid antibody formation against the recombinant enzyme have been identified as important factors to improve outcome. But morbidity and mortality are still high. Moreover, prolonged survival of IOPD patients has resulted in a new phenotype with variable residual muscle weakness and worsening of motor function after some years of ERT, hearing impairment, oropharyngeal and facial weakness causing speech and swallowing difficulties, as well as neurocognitive, respiratory, and orthopedic problems. Strategies to further improve outcome in IOPD and also LOPD focus on manufacturing improved enzyme versions that allow a better uptake into the muscle cell and developing gene therapies. NeoJA, a valglucosidase alpha, a modified recombinant human GIA with higher affinity to the mannose 6-phosphate M6P receptor, is currently tested in a phase 3 study and final results are expected soon. ATB200 is another rhGAA with a higher content of M6P and BIS M6P glycan residues that is tested in a clinical trial in association with a pharmacological chaperone. Albuterol has also been investigated as an add-on therapy which may enhance the lysosomal uptake of hRGAA. Moreover, there are several preclinical and early clinical ex vivo and in vivo gene therapy trials targeting different tissues with variable transgenes. To date, it is not clear which approach will finally be best suited for this complex disease.